I'm going to go out there.
Yeah,
Be
just
safe.
be far from the computer. Yeah, talk a little bit about AFib and actually be a good transition.
Whenever you're ready.
How's the microphone? Can everybody hear me okay? All right, well, welcome everybody. My name is Dr. Choudhuri. I'm a cardiac electrophysiologist here at Rutgers South. And it's my pleasure to introduce my team, Dr. Amin Rmeileh and Dr. Jessica Tommerup. Today we're going to talk a little bit about one very important aspect of management of atrial fibrillation, which is stroke risk, and the way a new technology for us and a solution that's been around for about 15 years now, called the Watchman, can help us reduce the risk of stroke as well as cost and side effects and complications for our community in Pleasant Prairie, Kenosha, and the surrounding area. So at last count, we have over 5,000 people today who suffer from highly symptomatic atrial fibrillation. Atrial fibrillation, and that's in our community, Kenosha, Pleasant Prairie, not even talking about Metro Milwaukee and northern Illinois or out to Geneva or And so it's a big problem that affects, generally speaking, it's considered 1 to 3 to 1 in 5 people above the age of 45. And really, as we all are living longer, I don't want to say we're getting older, we're living longer, and we're enjoying very fruitful lives and productive lives into our 80s and 90s. And people are still developing atrial fibrillation in their 40s and 50s and 60s. And this is a condition in which the heart rhythm changes so that the upper chambers now are no longer receiving one impulse at a time, but sort of 300 to 500 impulses all traveling through the upper chambers of the heart, called the atria, causing them to quiver or fibrillate, okay? And so what happens then is that blood is able to stagnate in the upper chambers, and in particular, there's an area or a pouch that sticks off of the atria on both sides called the appendage. Just like our colon has an appendix, we have an appendix of the heart. We actually have two of them. Well, the one on the left is particularly important because that during AFib, when our upper chambers or atria are not squeezing but just quivering, blood stagnates in that appendage and can form blood clots. Atrial fibrillation is associated with a 5 times increased risk of stroke, and 95% of those strokes are related to blood clots that form in that tiny little pouch. So if we can somehow remove that pouch from the rest of the circulation, we no longer need to have a conversation with somebody who's got AFib to also talk about you're also at risk for having a stroke. And it could be a devastating one, or it could be a minor one, and it could be happening in the near term or later in life. None of that we're not really able to predict. And so until now, even from the 1960s, we've been using initially rat poison, right, discovered at the University of Wisconsin, called warfarin, right? That's what the W is for, right? And that requires a lot of blood thinning or blood tests to find out if you're in the right range, and you can't ever eat a salad again, or you should always have the same amount of spinach. And now we've got newer medicines that are much steadier, they're a lot easier to use, and they provide a very effective level of thinning of blood to prevent blood clot from forming in the atria, in the appendage, so that somebody who has AFib, their risk of stroke is effectively mitigated. Not quite, but almost back to what it would be with the normal population. Roughly about 60 to 70% stroke risk reduction, and all of the real sciencey stuff and facts you're going to hear from Dr. Rmeileh. It's important that you have a reasonable understanding of what we're talking about and why we think it's very important. There's a lot of study and literature and science behind this. So for the last 15 years, and now with our expert team here, we're able to offer a catheter-based procedure that takes about 45 minutes through a vein at the top of the leg that allows us to get up to that appendage, drop off the little umbrella, the little Watchman device, leave it in the appendage, which then closes itself off over about 6 months so that people never need to use blood thinners again to prevent stroke related to AFib. And if you think about the amount of money that people spend, anybody here, maybe you don't want to share, but I know that people are paying out of pocket for various anticoagulants, hundreds of dollars every single month. And this is after all the companies tell you that they've got a discount card for this, and you'll pay 10 bucks for that, and then what happens when it runs out? You know, you still got, it's hundreds of dollars. And then there's drug interactions. And then there's falling, because it's not like we don't have snow and ice here 7 months out of the year practically. You know, and there's a lot of challenges with using these medicines for decades, right? We're talking about putting people on blood thinners potentially for decades because they're living into their 80s and 90s and they're developing AFib in their 40s and 50s and 60s. It's almost unconscionable, almost unconscionable. I have a hard time, I struggle telling patients that they may well need this medicine for the next 30 years. So we're happy to share with you some information about this new procedure called the Watchman. And I'll introduce Dr. Rmeileh, interventional cardiologist and newly chief of cardiology at Frederick South.
Thank you. Appreciate it. Thank you. Thank you. Thanks for everybody for coming. Just like Dr. Choudhuri said, this is a new technology, fairly new to Kenosha. We started in February here with our program, but it's been going on for years, 15 years, and we just wanted to introduce it to our population here. We're living in an exciting time. We're doing a lot of procedures that are less invasive, and the results are great. So this is one of them, and hopefully we can build up on that and bring more technology to Kenosha. I'm not as good as a speaker as Dr. Choudhuri, so I'm going to talk off my PowerPoint. But if you guys have any questions, there's going to be a lot of technical stuff, but feel free to ask, raise your hand and ask some questions. So left atrial appendage occlusion, or left atrial appendage. What is the left atrial appendage? Just like Dr. Choudhuri said, it's a little pouch of the heart on the left side that blood can collect, stagnate, clots, and if that clot moves for some reason to the brain, it closes an artery, then you get a stroke. Every person is unique. We have different types of appendages. This picture on the initial slide shows you how kind of the morphology, the way it looks is different. You have little lobes, 1, 2, 3, little pouches off the main pouch. So it gets very technical for us to get in there, but thankfully with the new device that we're going to introduce here that we're having, we're able to close most of these. So most of the time, 99% of the time, we're able to close it and prevent the clots from occurring in that little pouch. So from my outline is we're going to talk about stroke and how it relates to atrial fibrillation and how we detect atrial fibrillation. We're going to talk about the efficacy of anticoagulation therapy for treatment of atrial fibrillation. We're going to talk again about the left atrial appendage. We're going to introduce the Watchman. We're going to talk about the safety. People ask, it's a procedure, is it safe? It's a big deal. So we're going to talk about the safety numbers. We're going to talk how we select patients. Who is suitable for this procedure? And then we're going to talk about cost. I'm going to actually mention some numbers, just like Dr. Choudhuri said. So secondary stroke prevention, this is what we're trying to do. We're trying to prevent patients from having a stroke. If you had a stroke, you're already at a higher risk of having another stroke, especially within the first 6 months. And most of the strokes happen because of this irregular rhythm, which is atrial fibrillation. And that's what we call secondary stroke prevention. You had a stroke, we want to prevent you from having another stroke. Versus primary prevention, which we're going to do with a Watchman and anticoagulation, is that we detect atrial fibrillation. We don't want you to have your first stroke, because once you have your first stroke, you're at a higher risk of having your second stroke. So the medical team here has done a good job. Since the 1960s to the 2000s, we were able to reduce the stroke risk from 8.7% to 5%. That's still a high number. So imagine if you have 1 million patients with a stroke in a year, and you still have 5% that are having a stroke, that's 50,000 people. That's a lot of people. And that's about what we have, the stroke in the United States from a 2021 survey or analysis. 795,000 people get a stroke annually every year. 87% are because of blocked arteries, which we call ischemic. and 240,000 people experience what we call, mini stroke, transient ischemic attacks. So we try to define the stroke. Is it coming because your carotid is blocked? Is it because you bled in the brain? Is it because some clot occurred in the left atrial appendage and went to the brain? 88% of the strokes are caused by a blocked artery. 77%, more than 77% 35% are because of a clot from the heart. So we try to detect the atrial fibrillation because that's a lot of these blocked artery happen because of atrial fibrillation. Now the other percentages are happening because you have a blocked artery, because you have an artery in the brain that has some atherosclerosis, some buildup of plaque. For these, in the brain, we send you to the neurointerventionalist. They can go in and suck the clot or put a stent. Or we send you, if you have a carotid artery stenosis, we send you to one of our surgeons. They can clean up the artery. But a lot of times when you have it in the heart, we have to look in the heart. We have to put a monitor in you, make sure that you don't have atrial fibrillation. We do a procedure like an echo to make sure that you don't have anything on the valves. So 35% that are coming from the heart, that's a big percentage. How do we detect atrial fibrillation? I don't know if you guys are aware, every time you come to the hospital, you get an EKG, right? They hook you up to a monitor. We're always monitoring you in the hospital. That's why we're detecting atrial fibrillation more than like a decade ago. People were having strokes. People were coming into the hospital with a stroke and nobody knew why, Now we said you come into the hospital with a stroke, we put a monitor in you. You can have it for 24 hours, 48 hours. We call that a Holter monitor. Or we give you an event monitor for 30 days. And we also have other things that we can put a chip under the skin and they can monitor you for like 2 to 5 years. And if you ever have developed atrial fibrillation, we'll be like, okay, this is why you had a stroke. Let's treat you so you don't have another stroke. Also, the government can listen to you with the chip in the body. I'm just kidding. No. So atrial fibrillation and stroke. So like Dr. Choudhuri said, it increases stroke risk by 5 times. So 1 in 6 strokes occur in patients with atrial fibrillation, and your likelihood of having a stroke within 6 months, it's 2 times if you have atrial fibrillation. So today, for example, we have 6 million people with atrial fibrillation in the country. In 2030, it'll be 12 million. One reason of that, because Asian population, by the time you're 80, 1 out of 4 people will have atrial fibrillation. So 25% of people by the age of 80 will have atrial fibrillation. Age alone is a risk factor. So what are the guidelines? What does the American College of Cardiology say? What does the American Heart Association say? It says, okay, let's say you're 25 and you have atrial fibrillation because you were infected with something and you're in the hospital. How do you treat? Do you put you on blood thinners? No, because the blood thinners lifelong. If I put you on a blood thinner when you're 25 or 30, you're going to be on it till you're 80. Let's say you fell off a bike, you get in an accident, you need surgery, yada yada. Your risk is high. You're going to need blood transfusions. That carries a higher risk than your stroke risk. So we got to balance kind of a stroke risk and a bleeding risk, okay? So we have this little calculator that we use, and based on your numbers, based on your characteristics, based on your comorbidities, do you have high blood pressure? Do you have diabetes? Do you have congestive heart failure? How old are you? Are you female? Do you have vascular disease? That raises your stroke risk. And once you reach this critical number, which is, unfortunately, it's not that high, 2 for a male or 3 for a female, then we have to put you on a blood thinner. Okay? And this is to kind of reduce your stroke risk to normal. We want you to have the same stroke risk as somebody who does not have atrial fibrillation. Again, it's always a tricky point. So we want to prevent you from having a stroke, but what about bleeding? Some people, they bruise easily. Some people will need procedures. They need, like somebody with Crohn's disease. They need colonoscopies. They have, every once in a while, they have a bleeding episode. How do we balance that? We do have another score system that we use, but they're not really comparable. So for example, here I put it like a little kind of technical calculator. So we use a score system called the JASVASC. If your score is 3, your risk of stroke a year is 3.2%. Now the bleeding score, if you have a score of 2, your bleeding risk per year is about 4.1%. So the numbers don't correlate. Although you have your bleeding score is lower, you still have a higher chance of bleeding than the chance of stroke per year. So they're not comparable. So it's always been difficult for us in the medical community to kind of balance the stroke risk and the bleeding risk. The problem with the blood thinners is that the longer you're on it, your bleeding risk even increases. So for stroke, if there has been no changes in your medical problems, let's say you have only hypertension and for the next 10 years, that's your only problem, your stroke risk is the same. So it's not going to change unless you have another problem. You develop congestive heart failure, you develop diabetes, but that is your stroke risk. Unless you develop a new problem, your stroke risk per year is not going to change. If it's 3% today and you're the same person 10 years from now with the same medical problems, your stroke risk is 3%. But your bleeding risk, if you're on a blood thinner, it will exponentially increase in time. Just by aging alone, you will increase your bleeding risk. And that's the problem with being on blood thinners for a long time. Especially, once you hit the age, an age where your mobility is restricted, that would be a problem. So you fall, you hit yourself, it becomes a problem if you're deconditioned. And people, as they age, they develop other problems that might not affect their stroke risk, but will affect their bleeding risk. So here's a few pointers about how can we reduce the bleeding risk? Who are the people that we're looking at? So patients with a history of bleeding, these are patients that probably will bleed again. Somebody with diverticulitis, or some with a kind of a colon bleed, if they bleed once, their risk of bleeding again is high, just because the anatomy is already abnormal. Somebody with falling, somebody who falls, whether it is neurologic or non-neurologic, your risk of falls is high, you're going to fall again, you're going to end up with a bleeding episode. Compliance is always an issue with medications. Some of these medications, the blood thinners, you have to take it twice a day. Some of it you have to take it 30 minutes after food. You have to take it at night. Some of these medications like warfarin, which is the rat poison, like Dr. Choudhuri mentioned, you have to take it every day. You have to watch out what kind of foods you eat. If you eat any greens, it will affect the levels of the blood thinning in your blood. You have to monitor every month. You have to get a blood stick to make sure you're in the good range. So there's a compliance issue, and most people can't do that. It's hard to take 4 pills. Imagine if you add a 5th, a 6th. You have to take it multiple times a day. It becomes an issue. And if you take too much, your risk of bleeding is high. Occupation. So I have young people with atrial fibrillation, but some of them are young and they're working. And I have an electrician. He has atrial fibrillation, and every time he shows up, he has some bleeding in his arms. That's very uncomfortable. You're at work and you start bleeding on your clothes and the equipment. It becomes a problem. So these are patients that probably you want to consider taking them off the blood thinners. People who play golf, you don't want to get hit in the head with a golf ball when you're on a blood thinner. That's definitely a big no-no. It's a concern. We have patients that like to golf, and you don't want them to do. People with coronary artery disease. Let's say you have a heart attack, God forbid. You need a stent. You need to be on some other type of blood thinners that work totally different than the ones that we treat with atrial fibrillation. Most of it is like aspirin, and then another medication like aspirin. But if you add that to the other blood thinner, because they work differently, that raises your bleeding risk significantly higher. So it's hard to balance, and we have to cater to each patient. Each patient is unique with their unique characteristics, and we have to cater the treatment plan. Now, it'll be nice if we can get the blood thinners off the equation so that we don't have to deal with it. And that's what we're talking about, is that even with the new medications that Dr. Choudhuri was mentioning, which I'm going to mention, like Xarelto or Eliquis or Pradaxa, aside from being expensive, they still carry a higher bleeding risk, and the compliance is still an issue. Whoever is in Coumadin, which is the old drug that Dr. Choudhuri was talking about, the right poisoning, you have to check every month. It's a roller coaster. Sometimes it's, your level's too high, sometimes it's too low. Take an extra pill today, but skip 2 pills later. It's a roller coaster. We don't like to give it to patients. However, some insurance don't pay for the new medications because they're so expensive. Out of pocket for one of these medications is like $400 a month. Like, who the hell has $400 a month, every month, lifelong, just in order to prevent their stroke? That's crazy. Coumadin is cheap, but like I said, you still have to go and check your blood every month to check the level. if it's too high, if it's too low, can I eat this, can I eat that? It interacts with a lot of other medications. We need to remove this from the equation. Adherence, like I said, is low. So in terms of Coumadin or the new medications, the adherence is about, this is the chart. So for one of these, apixaban, which is Eliquis, the adherence is about 52%. So still 50% of patients are not taking their medications. Xarelto is the same, 47%. Pradaxa, which is dabigatran, is 45%. Coumadin is the lowest because you have to check all the time. Levels are high, levels are low, same problems. The compliance is about 38%. So the adherence. So that's very low, which means all the other times that you're not taking your medications, you're putting yourself at risk of stroke. I remember, many years ago in fellowship, I had a patient who came to the ER with a stroke. They called me to come see the patient. And I'm like, well, you're on one of these medications, the blood thinners. What happened? Oh, I needed to get a colonoscopy. And my doctor said to stop the blood thinner for 5 days before I go for the procedure in case he takes biopsies. And after that, after I went home, my arm, felt funny and I can't move it and came to the hospital with a stroke. Just because she stopped the blood thinner for a few days, she got a stroke. And like I said, as we get older, we have to do more procedures. Your colonoscopy, if you have polyps, is every 3 to 5 years. When you're younger, you don't worry about it. You're 45 and younger, you don't need to have a colonoscopy. But as you get older, the surveillance becomes more frequent because also we don't want to have cancer either. So these are the issues that we have to deal with the blood thinners, and that's why it's good when it was the best option that we have. Now we're looking for alternatives. So this is kind of some of the devices that we use, or they were experimental in terms of closing this little pouch that we call the left atrial appendage. So you can see on the left upper corner, the original Watchman, the legacy Watchman, that had a little bit of tentacles at the end, right here. That was kind of the initial one that we were putting around. Now they made several advancements and there were several changes. So the one that we're using here today is Watchman Flex. It's a much safer device. There's a competitor called the Amulet. Has not been in the market for so long. It recently, over the past, I think, 2 years, got approved, FDA approval in the US. They use it more in Europe. The data is not as robust, so of course we want to bring the best to Freighter South, so we use the Watchman. And this is kind of historically, what kind of devices they've been using to close the device. They look funny, they look weird, but kind of do the same thing. The whole idea is to close the pouch. And also there's surgical intervention, like the lariat. They kind of put lasso around the appendage and they close it off. And then if you go for surgery, open heart surgery or valve replacement, the surgeon can go in there and clip it. Now, not everybody's going to have an open heart surgery, despite how much the surgeons would love to. But so now we have this endovascular approach, which is a minimally invasive approach to kind of close the pouch without having to open the chest, which is kind of nice. So the old recommendation was that, it is for people who have a contraindication for long-term anticoagulation. So for people that, let's say, they can't be on blood thinners for a long time, but they can be on it for 6 months, then okay, you can go for the procedure. But now, the indication has widened. We don't even need you to take a blood thinner for 6 months or 45 days. You don't even, after we're done with the procedure, you don't need to take any of these new blood thinners. We give you an aspirin and something like aspirin called Plavix. You take it for 6 months. After 6 months, all you need is a baby aspirin. That's it. And this is kind of the studies that we've been through to approve this device, and look how safe it is, how efficacious it is. The pilot study was started in 2002. The Legacy, which is the old device that I showed you, they started implanting this device in 2015. The new device, what we call the Pinnacle Flex, FLX, is in 2018 with 400 patients. And now it's been about 16,000 patients from the new registry. Every device that we put it in the registry, and we monitor these patients whenever they come to the hospital. We see what happens. Did they have a stroke? Did they have a bleed? And you are added into this list. And now we have, since 2018, we have this thousands of patients that we can look at. We look at the data and we see how good did we do. This is a little kind of a comparison between the new device and the old device. The old device has this open-ended kind of tentacles or anchors. The new device is closed. This helps the new device stay in place and not cause any problems like perforations. The delivery system has changed. The way the mesh on the device looks is better, so it can be incorporated into the body. So, once we implant this, it takes about 6 months for your skin to grow over it, and it becomes part of you, and that's it. It's not going to go anywhere. It's not going to go anywhere from the time we put it in because it has these little anchors, but your skin grows over it from the inside, and then, it becomes part of your body, and, nothing's going to attach to it, and it's safe, and that's it. So long-term efficacy, the chance of having a stroke is 1.7%. What does that mean? It means it reduces your stroke risk to a normal person. So your stroke with the device is as it would be with a normal person or with somebody who's on a blood thinner. Now, in terms of complications, 0% pericardial effusion. What does that mean? During the procedure with the old device, these little anchors that I talked about, the open-ended anchors, they can poke a little hole, they can cause blood to accumulate around the heart. It doesn't happen anymore. We don't see it. It's 0%. Device embolizing, what does that mean? If we try to put the device and it kind of goes somewhere else where we don't want it, it moves out of place. That 0% doesn't happen. How are we effective in closing this little pouch? With the new Watchman Flex, it's 100%. Patient stopping the blood thinners within 45 days is 96.2%. You might ask, why is it not 100%? Because people have other indications for blood thinners. Let's say, you develop a clot in your leg, then, you'll be on the blood thinners. Let's say there's a little clot on the device after 45 days, they might continue a little bit longer with the blood thinners. But mostly what I've been seeing in the past 3 years, really, after you put the device, nobody's on blood thinners unless they have another indication. So a complete closure comparison, this is the new device versus the old device. The new device is in the orange. After 1 year, 89% closure. What does that mean, complete closure? We look for if you have a leak within the device more than 5 millimeters, which is really, really small. This is for us to be kind of very accurate. Most people, 89%, don't have that 5 millimeters. Some people do. We monitor these patients. We do a transesophageal echo. We do a probe with an ultrasound in the esophagus. We look at the device. We look at the leak. We do it at 45 days and at 6 months. So far, we've been seeing we have 100% closure. There's no leak. But we're talking about 16,000 people, 16,000 implants. So it's about 89% at 1 year. I like this chart because it kind of shows you what's the stroke risk if you have atrial fibrillation without treatment. And you can see this is an exponential increase in stroke risk. But if you are on a blood thinner, it kind of drops you down much less. So this is ischemic stroke risk events per 100 patient years. And you see how all these studies kind of fall here with the Watchman, kind of gives you the same benefit as if you were on a blood thinner. Now, from real-world analysis, which is the SURPASS, let's say all these patients that we planted the device in, the 16,000 patients that I talked about, it drops you even more than if you were on a blood thinner. What does that tell me? It tells me, hey, maybe this device is even better than a blood thinner because it drops my stroke risk almost to zero. This is a little bit comparison between the Watchman FLX and the Amulet. I'm just going to summarize it. The Watchman gives you better procedural success. The effective closure is 100%. The related complication is 0.5%. And device-related clots or thrombus is 1.8%. Compared to the competitor, which is the Amulet, and compared to the old device, this is better data, and that's why we're bringing this here. So this is the new study that I said, the 16,000 patients. The analysis was from August 5th, 2020 to March 31st, 2021. The safety, major procedural event rates, like something bad happening, like a perforation during the procedure, is 0.37%. Only 60 patients out of the 16,000 patients had a problem. And if you look into the details of the analysis, the patients that had a problem is because the operators are inexperienced. Like, let's say if somebody done one of these or two of these and trying to do this procedure, might have a higher chance of a patient having a problem. Good thing here, we're very experienced in this, so we're not going to fall into that group. Simplicity, the procedure success is 98%, and having a complete seal, like I said, about that 5 millimeters. So at 45 days, 95% of patients had less than 3 millimeter leak, which almost complete occlusion of that pouch. So this is through all the studies that have been done. The procedure success is over 97%. Your 1 year stroke rate from all kind of strokes, 1.6%, ischemic strokes, 1.2%. What does it mean? It brings you down to a normal stroke risk. So that's the whole idea, is bringing you down to a normal stroke risk, like you did not have atrial fibrillation. The new thing that came out in 2019, 2020 is this, we kind of even, in the beginning with the old device, we had patients continue their Eliquis or Xarelto or Coumadin, warfarin for like 45 days and then switch them to like aspirin and Plavix, aspirin and a medication like aspirin for duration of 6 months. The new data shows that we don't even need you to be on a blood thinner for the first 45 days. Once you get the implant, you just take a baby aspirin, 81 milligrams, and a medication like aspirin called Plavix, 75 milligrams. You take that for 6 months, and after the 6 months, you drop the Plavix, you just stay on a baby aspirin. So that's kind of nice. And there was no difference. So again, who are eligible for this procedure? Which patient are we going to bring to get this procedure? Who am I recommended? Which patient am I recommended this for? So first of all, you got to have an increased stroke risk. We talked about these little calculators earlier. You have a bleeding risk and you have a stroke risk. If you're a female, it's 3. If you're a male, you're 2. Anything above that, we kind of put you on the list. You need protection from stroke. You already need the blood thinner, but we want to get you off the blood thinner because of your bleeding risk. You have to be suitable for antiplatelet therapy. You have to be able to take aspirin. If you're having an active bleed, you're not the patient that you're going to take this. During the procedure, we give you a lot of blood thinners. You still have to take the baby aspirin and another medication like aspirin. If you can tolerate those for 6 months, you're going to be suitable. And then somebody has to talk to you. So we talk to you about the procedure, how it's going. You have to talk to your primary care physician. You have to do what we call a shared decision making. And if your primary care says, hey, I think this is a good idea, you should do it, because you don't want us, it'll be a biased opinion if I'm the implanter and I recommend this to you. I'm an interventional cardiologist. I'll tell you, hey, I think this would be a good idea, but I want you to talk to your primary care physician who is not involved with the procedure to get their idea about this. If they think this is a good idea, we'll proceed. And that's kind of, we want to be as, how do you say, we don't want any bias, we don't want to be doing Watchmans on everybody. That's not the whole idea. The whole idea is find a suitable patient and make sure you get a second opinion to tell, yeah, this is good. Most primaries are on board with this. Some of them are not familiar with the technology, and we're trying to educate people, the patients and the provider about what a Watchman is. All right. So cost. I said I'm going to talk about cost. So for cost, you're buying these medications, the blood thinners, for the rest of your life. Once you have atrial fibrillation, like I said, your stroke risk is still high, and you lower it with these blood thinners. So as long as your blood thinners, you're good. The cost is a problem. Even Coumadin, warfarin, which is the cheapest blood thinner that we have, is still costly. Okay, so they did an analysis here about the cost of warfarin over 5 years, which is the cheapest drug. It's going to cost you in about 5 years about $10,000. Okay. If we do the Watchman, you have a 53% less expenses in terms of, even if it's a procedure, you're going to be in the hospital for one night, it'll still be less expensive in 5 years. Actually, and if it's other than warfarin, let's say it's Eliquis or Xarelto or Pradaxa, you will reach that less expensive point at 2 years instead of 5 years. Just the cost is tremendous with blood thinners. And you get off one of these medications off your list. So a typical Medicare patient in 2021 will pay no more than $2,185 out-of-pocket cost to receive the Watchman. This includes everything from the screening echo that we do before, the procedure itself, and the echoes that we do afterwards, which we do one at 45 days and at 6 months. It will still be much cheaper than being on these blood thinners for a few years. So it's a one-time procedure. It reduces your stroke risk to normal. It takes us actually, we've done some that are less than 30 minutes. What takes longer is getting you on the table, getting general anesthesia involved, getting you cleaned up and prepped for the procedure. But from stick to finish will take us about 30 minutes. Okay, but we tell you an hour because other things are involved. It involves a small stick into a vein in the groin, in the right groin. We go all the way up to the heart with some wires and some tubes right here. We try to look where this little pouch is. Then we kind of advance another catheter in, and then we advance the device, and we release it. And then you're done. What happens after that? You go somewhere on the floor in the hospital. You stay for one night. Just make sure that you're okay, nothing happens. And then the next morning, you're gone. So let's say we do it at 8 a.m. or 9 a.m. The next day before noon, you're out of here, which is kind of nice. People don't want to stay in the hospital. I don't want to be in the hospital either. So, and the medications that we put on, aspirin and Plavix, these are cheap drugs. The aspirin you can get it over the counter. You can get 90 days for like $5. And then the Plavix is the same thing. This is kind of what we're looking at when we're doing the procedure because it's under X-ray. This is kind of the device being deployed in the little pouch, the appendage. And this is after we release it. And just stays in there. And that's it. So I kind of talked about, what the device is for. We talked about why blood thinners, they're good, but, certain populations are bad. We talked about the technology, how we went through from 2005 till today, how the new device is way better than the old device. We talked about how efficacious it is, how safe it is. We talked about how we put it in and how safe it is to put it in and the length that you have to stay in the hospital. And we talked about cost. So if you have any questions about any of this, please let me know.
So if you have this device, and let's say you have an event and somebody's going to do CPR, is it brought in place?
Okay, so the question is, let's say you need compressions. Let's say you pass out, you have a cardiac arrest, and you need compression. Is this device going to move out of place? So this device has a lot of anchors. So after we put her in, we do a test, what we call a tug test. We try to pull it out of place and see if it comes out, and it doesn't come out. If it does come out, the procedure is not successful. So before you get off the table, we make sure it's not going to move. Other than that, within 6 months, your skin will grow over it. It will become part of you, so there's no way this device will move.
Will it hurt?
You will not feel it.
No, I mean, if you had to have CPR, will it hurt the rest of your heart to have that injury?
So the question is, will it hurt? Is while you're having CPR, will it hurt? It will not. What will hurt is the CPR.
Are you asking will having CPR hurt the device?
Yeah, but will
No.
the device do something to your heart?
So in certain circumstances, let's say if you're very early after a procedure, CPR, of course, when it's done properly, is quite aggressive. Sometimes ribs are breaking and everything is getting squashed and compressed so we can, from the outside, move blood through your circulation. And so there is some intended aggressive manipulation of the chest wall, and the heart. It's conceivable that it could dislodge, or potentially that the barbs could be driven deeper into the muscle, which generally is not a problem, but could there be some fluid that then collects around the heart? Those are, I guess, theoretical considerations. We certainly don't want anybody who is responding to a cardiac arrest, meaning doing CPR, to let off the gas because you may happen to have a Watchman in place. And the first responders are able to manage cardiac arrest very well. And when we do get you to the hospital after you've been resuscitated, everything is looked at again. Imaging from a variety of perspectives, whether it's ultrasound, x-rays, CAT scans, and a variety of things, so we can make an assessment of what do we need to do next, including has there been injury to the heart or the great vessels that now continues to put you at risk. And then we need to bring Dr. Laga, get Dr. Laga involved, or our trauma surgeons involved. So we look at all of that after the fact, but we don't take that into consideration at the time. If somebody collapses, we want very aggressive and well-performed CPR.
On these Watchmans on the appendage, are the appendages all the same size? Well, or does this Watchman come in different sizes, the 58?
That's a good question. So the question is, does it come in different sizes? If you guys remember the first slide here. So no, they come in different sizes.
They do?
They do, because every appendage is different. So we try to measure it before. We do an echo or a CT scan kind of a month or a few months before to size it ourselves. And then we select a device based on that size, based on your appendage size.
Right.
And then during the procedure, we size it again to make sure that we have the right size.
And also, just 1 second, you mentioned about 2 appendages on a heart. So you only close one or both?
Yeah, we look at the left atrial appendage because in the historical literature, in people who had a stroke that was attributed to atrial fibrillation, when they found a cause, it was related to a blood clot that in 95% of those people were located in the left atrial appendage. So that's one line of evidence, so to speak, that directs us to that side. But the second more practical consideration is that the left atrium is directly connected with the left ventricle, which is directly connected with the aorta and the rest of the circulation that goes to the brain and the heart and the gut and the rest of your body. So if a blood clot's going to travel out of one side or the other, it's going to be on the left side, which then goes places and causes a problem. The right side also has an appendage. We typically don't see clot forming there. And if a clot does dislodge from the right atrial appendage, it goes through our body's natural filter that protects the left side, called the lungs. The lungs are the vasculature to the lungs are highly networked and branched, and so these little blood clots may get lodged in one of these branches, large or small, but the majority of the blood circulation continues to flow without much impact most of the time. In fact, we're all forming blood clots and dissolving them all the time in our system. And we're dropping clots and dissolving them all the time. And so the lungs serve as a natural filter for blood clot that may occur on the right side to protect the left side.
Would anti-arrhythmics be a viable alternative?
Dr. Choudhuri, he deals with antiarrhythmics more.
So, and I know Dr. Laga would agree with me that the best way to protect people against stroke is keeping them in sinus rhythm with exceptional durability. If you can keep somebody in sinus rhythm, the risk of developing a stroke from atrial fibrillation effectively goes away. Right? And you can even make the case that if you knew 100% of the time that they were in sinus rhythm, we wouldn't even be concerned about blood thinners. Because we know you're in normal rhythm. You're not having AFib, you're not creating a quivering of the atrium and then predisposed to forming stagnant blood in blood clot. So the question of antiarrhythmics relates to how do we keep you in sinus rhythm? How do we keep you in your God-given normal rhythm? And there are a variety of ways to do that. The time-tested way is an electrical shock called cardioversion that puts your rhythm back to normal. And we know that as we all get older, longer episodes of AFib usually correspond to shorter durations of maintaining sinus rhythm after cardioversion. And so we say, what else can we do to help keep people in normal rhythm? Antiarrhythmics are one way, and ablation is another way. Ablation is done today 3 different ways. One is a traditional catheter approach. One is a combined catheter with surgical approach where we're using a small incision below the sternum, where Dr. Laga and the surgeons can get in underneath the sternum bone and do ablation on the outside of the heart. And then the third way is through open heart surgery, either independently as a standalone primary procedure or in association with other heart surgery that somebody may already need, such as to fix a valve or for bypass surgery. So whichever way that you choose to maintain sinus rhythm effectively and with a high level of confidence, including the use of antiarrhythmics, is the best way to physiologically to prevent stroke. But that's challenging to do for a variety of reasons. And so we try to go directly to the source of saying, let's eliminate the appendage as an area where blood can stagnate, whether it's done through a catheter-based endocardial approach or a surgical approach, which could be a clip, it could be a ligation of the appendage itself, a surgical tying off of that pouch. Irrespective, at least we know we've effectively reduced or eliminated the risk of stroke while we now address a harder problem, which is how do we confidently keep somebody in normal rhythm?
So, I just want to add to that. Even if you go through all these procedures to keep you in sinus rhythm, none of us can say 100% that you're not going to have atrial fibrillation again. You could be one day you have an infection somewhere, you end up in the hospital, it irritates your heart, and you can go in atrial fibrillation despite all the procedures that we try to do. So there's 2 ways of attacking or treating atrial fibrillation, or 2 things that we have to worry about. First is making sure that you stay in the normal rhythm if we can, and the other one is to protect you from stroke as much as we can. So staying in rhythm, in normal sinus rhythm, protects you from stroke, but we can't guarantee that it's going to be 100%. So we're going to make sure that we treat the stroke risk either with blood thinners or with the Watchman left atrial appendage closure, and then also we try to keep you in sinus rhythm. So we have to attack 2 issues when you do have atrial fibrillation. Go ahead.
Yeah, you had said that sometimes if people have open heart surgery, that they remove the appendage, then the Watchman wouldn't have an effect if it.
We certainly wouldn't consider delivering a device into a space that no longer exists.
Yeah. So that.
Exactly.
Yeah.
And so your point is
Yeah.
exactly.
Okay. So just to repeat it because you don't have a microphone. So the question is, if somebody has open heart surgery and the appendage is ligated or clipped, do you still need a Watchman? No, basically, because basically the appendage is no longer there. So, yeah.
Do they routinely do procedures on the left atrial appendage during open heart surgery?
Do they routinely do procedures on the left atrial appendage during surgery? That's a good question.
Why don't we ask Dr. Laga?
Dr. Laga is our surgeon. He's our new cardiovascular surgeon. He'll be able to.
The short answer to the question is absolutely yes.
So absolutely yes.
There is a gigantic study that's being done at Northwestern where this question is being definitively addressed, but there have been many, many studies that, most recently from the Loyola group, that have strongly indicated that if you go into the chest for any reason, in other words, you're going for a long operation on the left side, or if you're doing coronary bypass surgery or replacing the aortic valve, that certainly ligation of the atrial appendage can be accomplished in less than 2 minutes and with virtually no morbidity.
All right. So yeah, so if your chest is open and you can get rid of the appendage, might as well do it. And I think it's becoming more frequent, more standard of care to do so. A lot of patients, even after open heart surgery, will have atrial fibrillation, and you have tubes, and you don't want to be placed on blood thinners right after surgery. So taking care of it during surgery is the best treatment option. So, yeah. Go ahead.
What about people that have a minimal episode of AFib?
A minimal episode of
Yeah, it doesn't
AFib.
happen frequently.
Right. Great question. That's a question that the cardiology and the electrophysiology societies continue to struggle with. How much AFib actually increases your risk of having a stroke? Because in reality, if we all wore monitors for a few months, we'd find a little bit of AFib in probably all of us, even if we never had any identified or diagnosed history of AFib. And so there's a couple of studies that have indicated that even as little as 6 minutes of AFib, statistically, meaning in a large population, you can find a difference in their stroke risk. However, we don't put anybody who's got 6 minutes of AFib on blood thinners, and that's because we don't know that the benefit of that blood thinner is actually going to, the risk of it may exceed most likely the benefit of stroke reduction, stroke prevention for 6 minutes of AFib. So there's a second study done in people with atrial fibrillation that was identified if they already had a pacemaker or a defibrillator in place. So for people who have a pacemaker or a defibrillator, that's already their onboard, almost lifelong cardiac monitor that identifies when somebody may have an episode of AFib. And what that study showed, the TRENDS study, showed that if you had more than one 6-hour episode of AFib within a 30-day window, that there was a benefit to starting you on blood thinners. So all of those patients were put on, if they had AFib identified on their device, they were put on blood thinners. But the group that seemed to have a true demonstrable reduction in stroke risk was only if they had a certain amount, meaning the burden of AFib was at least 6 hours across 2 episodes within a 30-day window. So it's not just AFib, but it's an episode that's long enough and it's happening frequently enough. So short episodes of AFib likely do not independently increase your risk of stroke on their own. Question is that a harbinger of something that's happening more often that we're just not aware of? Because 50% of people with AFib don't even know that they've got atrial fibrillation. They don't feel it. And that's the biggest concern with, as you mentioned, our ability to effectively rely on what we think is maintaining sinus rhythm. They studied this in the past in a trial that was published in the New England Journal back in the, I think, 1990s, in the AFFIRM trial. And they found that they were stopping blood thinners in people who they felt were in sinus rhythm. And those people in whom that they stopped the blood thinner were actually having strokes. And the people who were on blood thinners were not. And so what they found was that there was no benefit if you were in AFib or not. But the real difference was because one group was not on blood thinners. And so we take stopping blood thinners very seriously. We want to know that you're staying in normal rhythm, and certainly if your AFib burden is low enough, then we feel much more confident. But we also want to be confident that we know that you're not having episodes that you're not aware of and that we're not aware of.
So I just want to add to that, it's unless you have a monitor that can, continuously monitoring you, we would never know how much atrial fibrillation you have. I mean, the longest, I think, monitors, loop recorders that we have is like 5 years. So who wants to take the chance? And also, like I said, on the stroke calculator that we use, the duration of atrial fibrillation is not part of the calculator. If you're 80 with high blood pressure, diabetes, and other risk factors, or if you ever had a stroke because of atrial fibrillation, raises your risk of stroke tremendously, that you probably need protection, whether it is 1 minute or a whole day. You need something to protect you from the stroke, which is unrelated to whether you're in sinus rhythm or not.
So I want to interject here. I want to introduce Jessica Tommerup. She's new to our team from October of 2023. She is the Watchman coordinator for Freighter South. And as the only organization that's offering this, she is the coordinator for all of Pleasant Prairie and Kenosha and Lake Geneva. And as far as you're willing to drive, reach out to people. So I want to make sure that while we are here to answer your questions that may be clinical about AFib and management, that we give Jessica an opportunity to share with you what we're doing today and how we're getting directly in touch with you and what our process is when we see you in the office or you come and we talk about AFib, how we think about managing AFib, but also how we manage stroke risk and the process of being evaluated from visit to stopping the Plavix after your 6 months after the Watchman delivery. So do you want to take a few minutes and introduce yourself further and tell us a little bit about our process?
So like Dr. Choudhuri said, my name's Jessica, and it's actually been a pleasure to join the team here and be a part of growing this program and seeing the success that we've already been having since our January implant. So as far as the referral process, we've gotten a lot of internal referrals from primaries to the cardiologists within our clinic, to patients that Dr. Choudhuri and I are already seeing for AFib. So really coming from every angle.
And what about people who just come in and say, I want to hear about it myself. My doctor didn't mention it, but I saw it on TV, and they come and see us?
Absolutely. Make a follow-up with me in the clinic. I'm happy to discuss in the clinic within an appointment. A lot of times when there's referrals from the cardiologist within our clinic, I do a lot of conversations over the phone, answering questions. I encourage patients to please call. I'm happy to go through anything as you read through the literature, look at statistics, look at the Boston Scientific website. So there's a lot of good information out there, and I know there's a lot of questions that come up after that's reviewed. So I'm happy to go through anything with the patients. Once the interest is there, we get the ball rolling with the pre-imaging. Once that's done, we review the imaging with Boston Scientific, confirm the measurements, confirm that the appendage is suitable for closure, and then we work on getting the procedure scheduled, having that visit with your primary care doctor, getting the appropriate documentation for insurance. If there's a prior authorization that's required, we do that on our end. So we try to make this as smooth as possible for the patient, the family members. And then after the implant, there's some follow-up with the imaging. I keep in touch with you in regards to the results of how those turn out. So we try to make it as seamless as possible, coordinate it with people who have to travel, who want to take vacations. You know, we're very flexible in that regards too. So it's really been a learning process. I think we have a nice smooth transition for patients, and it's been a joy to work with these doctors so far with this program.
Jessica's really ramped up the program here, and the success of the program and the growth of the program sits squarely on her shoulders, as well as on the fourth and maybe most well-known but least visible person of our team, Rachel Rocha, who's in the back. Most of you probably know her already, either if you've been in my clinic, then you've been working directly with her, or if you've seen her around the hospital. But this is the team that is going to guide you from very beginning to end through your journey related to atrial fibrillation management, including Dr. Laga and his team behind him, and inclusive of the management of stroke, including the Watchman program. So we're all here. So this is your opportunity if you want to talk to us, if you have questions. Otherwise, certainly we'll be available through, I think there's ways to get feedback over to us as well. And our cards are there as well. And we look forward to more questions now or another time, or otherwise seeing you in the future.
How many Watchman procedures have been done here, and how much experience do the doctors have in actually, how many procedures have they done?
So we've done our first 22 now? What's our number?
20.
20.
20
We've done our
successful
first-
implants,
We've done our
yes.
first 20, and then what's our aggregate experience in
I don't know, I was trained on it. So from training in 2017, I've been involved in somehow putting these in.
So 6 years of Watchman. Dr. Rmeileh is our local expert here, trained at one of the large academic high-volume centers, and so he's the primary operator. As I develop my technique for the Watchman. And so just so you understand why it's important for interventional cardiologists and electrophysiologists to be working together, not only because we've got an extra set of eyes and an extra set of hands that can keep a variety of things in view, but when the original study was conducted, it was conducted with interventional cardiologists who had not spent as much time in the left atrium, whereas the electrophysiologists had. And so that study was temporarily stopped to revisit the expertise that was required to do this effectively and successfully. And since that study and then all subsequent applications in clinical applications in the US with Watchman and left atrial appendage occlusion, the best programs and the most successful programs are those that deliver this through a joint effort, a four-handed approach, a joint procedure with interventional cardiology and electrophysiology.
Who actually does the procedure? Or
We
are
both do.
You're both
We both
involved?
do, yeah. We both do. So we both do delivery of the Watchman as a primary operator. We both do management of wires and catheters and tubes as the first assist in the scrub as the secondary operator. So that way we're both available at all times, keeping track. And that way we can switch if we need to. So if there's something that Dr. Rmeileh says, hey, can you take a look at this? Or if there's something that I say, hey, I'm having a little trouble, why don't you give this a shot? We're both there. So we don't find ourselves at any time stranded.
So, the whole idea of this lecture is to introduce it to the community. So this is a new technology that we wanted to bring to Kenosha so the population can benefit from it. It's been around forever, not forever, 15 years. Where I was in training in Florida, I was in a county hospital, Broward County Hospital. It was the highest implanter. They do 100. They did 100 with the initial Watchman device. And then after I moved to training, and then my first job, I was implanting. So it's new here. We've done 20, and that 20, 0 complications. We have no problems in terms of device issues, or once the device is in, things have been smooth. And I think I did the 6 months follow-up on one of our patients a few days ago. He's off the Plavix, he's on a baby aspirin, and he's doing great. So that's the whole idea. We want to build this program, and hopefully more patients can benefit from this.
Yes.
I have a question about after the procedure, directly after when you go home, what are your restrictions?
So from a procedural standpoint, it's really just letting that growing site heal. It's a venous approach, so a lower pressure system, lower risk of bleeding, but we still need to make sure that that heals up nicely. So for the first week, there's some lifting restrictions, no prolonged bending, instructions that the nurses go through with you. But really after that week, allowing that growing site to heal, we want and encourage you to do what you want to do, gardening, walking, all that activity.
What about driving?
Driving's okay.
After 1 week?
Yes, yes.
So you don't want to break on the pedal real strong and kind of pop the suture. We kind of close the vein with a suture. Now from the device itself, we make sure nothing happens while you're in the hospital. That's why you stay one night. We do an echocardiogram the next morning to make sure that there's nothing happened there. We do an X-ray in the morning, make sure nothing is there. And that's it for the device. Now, for the groin stick, for the venous stick, you just have to make sure that you don't, like Jessica said, don't bend, don't lift anything heavy for a week, because it needs to heal, it needs time to heal. And after that, you're good.
Are you in ICU, or are you just going to the hospital after surgery?
We put you on a floor that is a cardiac floor. You don't have to be in the intensive care unit. We were initially putting patients in the ICU because we wanted the extra care with the nursing.
Right.
But I think at this time everybody's trained to take care of the patients on the step-down unit, which is kind of a cardiac
heart-specific unit, and patients have to do it well.
I think that plus we've really solidified our approach and our technique to deliver the Watchman and perform the procedure effectively, safely, using high standards that really were developed by Boston Scientific over the last decades and more, with what's going to ensure a successful procedure.
Any other questions? Thank you for coming.
Thank you.